Hello. I want to thank you for watching this today. I am Matt Zuckerman from the University of Colorado School of Medicine and the Rocky Mountain Poison and Drug Safety. Today, I'm going to be talking about an introduction to the management of patients exposed to toxins. Some disclosures. This work is funded by a grant from the Administration for Strategic Preparedness and Response. The content of this talk is my personal content and does not represent the official policy of the US government. And this talk is not meant to be a substitute for professional medical advice, diagnosis, or treatment. I have no other conflict of interest to disclose, no relevant financial interests or relationships. And now that we've gotten through that, let's start with some clinical information. Let's say you're a paramedic or you're a first responder and you're responding to an uncertain situation. This actually happened. This was a theater hostage crisis that occurred a number of years ago in Russia. There were 50 hostage takers. There were 850 hostages, and the EMS system had been notified that there was about to be a siege of the theater and that a chemical was about to be administered to assist in that siege, but they weren't told what it was. So all of a sudden, this strange gas started to enter the theater through the ventilation system. And when EMS entered, they found hundreds of people down on the ground, decreased mental status, small pupils, apneic, and it was really a question as to how to respond because they weren't told what the agent was. And so the things that they were going through is this a nerve agent? Is this an opioid? Is it something else? And those responders that understood how to respond appropriately to an undifferentiated patient administered the right treatment and helped save lives. Summaries for this talk are going to be knowing how to evaluate the tox patient, recognizing the types of exposures, and then understanding what comes next. Now, when should you consider that a toxic exposure has taken place? Because that doesn't always come up when you're being told where you're going. Sometimes it's a known exposure. You get told this person was exposed to hydrofluoric acid, this person was exposed to organophosphate pesticides, but sometimes you don't know. Knowing the site of exposure can be helpful, and certainly don't memorize this table, but these are the kinds of tables that poison control and hazardous response will use when they're thinking of in an artificial nail application site, there might be acetonitrile or methacrylate. In an auto body painting shop, there might be isocyanide. Certainly, if there's paint stripping, methyl chloride. If there's concrete applications, there could be chromic acid, fermentation, CO2. Everyone's favorite manure pit or sewage operation that knocked down hydrogen sulfide gas. So understanding what agents and solvents are used at a site, what MSDSs might be available can be certainly helpful. And if you don't even get that information, just when you see multiple patients who present with the same symptoms, it's important to consider a toxic exposure. The main time that's going to happen is with either a communicable disease or a toxic exposure. And before we dive into management, it's really important if you do suspect a toxic exposure to take a beat and think about your safety. Certainly, this is not a substitute for following your own hazmat protocols and safety protocols, but ask yourself whether you should remove yourself from the area, whether it's safe to stay there, whether you should remove the patient from the area. Certainly consider decontamination. For liquids, this might be removing the clothing. Certainly during the Tokyo sarin attack, there were a lot of first responders that got secondarily exposed to nerve agents and did develop some symptoms. So with liquids, remove the clothing, consider flushing the skin with water. If it's a powdered exposure, consider brushing it off and then flushing away. And certainly consider appropriate PPE. We can't dive into the details of all the PPE, but I do mean appropriate. That's enough safety, be it respirators or other PPE to keep you safe. Recently, concerns over fentanyl have led to people responding in full scuba type apparatuses, and national toxicology associations have suggested that this over preparedness in PEPE might actually make your job harder. So appropriate PPE, considering your safety, is important. And I like to break this down into a couple of different things. First is knowing the patient. So the history, what happened? What were they exposed to? When were they exposed to it? Was it 30 minutes ago? Was it 6 hours ago? How long were they exposed and how were they exposed? Did they breathe it in? Was it an ingestion? Was it an injection? Were they in it for hours? Were they in it for 5 seconds? And how much of it were they exposed to? Very often it becomes important to ask several people these same questions to get an accurate history. The tox exam, which we'll dive into in detail later on in this talk, and certainly vital signs. Are they tachycardic? Are they bradycardic, suggesting a calcium channel exposure, a beta blocker exposure? Are they hypertensive? Are they hypotensive? Are they hypoxic and do they require supplemental oxygen? Is there a fever? Which I think we often ask ourselves when considering an infectious illness, but certainly with serotonin toxicity, the presence of fever can be concerning. With sympathomimetic toxicity, hyperthermia can be prognostic for a poor outcome. And then certain studies, which will definitely vary depending on the site of care, but at least considering a glucose and an EKG. Now, the tox physical exam, this is a focused exam that's focused on looking at specific tox findings. So the vital signs, as we've already alluded to, the neurologic exam, which can include the mental status. Do they have a depressed mental status or are they agitated? Are they confused? Do they have pinpoint pupils or dilated pupils? Are they reactive to light? Their tone, if they have increased tone, that can be an important finding suggesting NMS. If they have decreased tone, could there be some kind of botulism or other exposure? And their reflexes. This is actually something that's really important. I always dorsiflex the feet to see if there is a presence of clonus that stretches the Achilles tendon. And certainly if that foot beats back against my hand, if it's a few beats, I ignore it. But if it's sustained clonus, then that can suggest serotonin toxicity. So that's important to find. The cardiovascular findings, in addition to vital signs, this is where checking cap refill, checking perfusion can be really important. It's something we do well in kids and we don't always do it so well in adults. Respiratory exam. So do they have increased respirations or decreased respirations? A tox exposed patient who has hypoxia and decreased respirations might be suffering an opioid toxidrome. If they have hypoxia and increased respirations or they're hyperpnic, certainly they might have salicylate poisoning or they might have a non-toxicologic source of problems. Their lung sounds. Classically, we talk about that bronchorrhea associated with cholinergic poisoning, so it's important to listen to their lungs. Abdominal exam may seem less important, but certainly you can find decreased abdominal sounds associated with opioid poisoning, increased abdominal sounds in other states. Their bladder, which is rarely actually palpated, but certainly a distended bladder can be an indicator of an anticholinergic exposure and can actually be a source of agitation. Relieving that distended bladder with a Foley can sometimes help decrease agitation. And skin. Skin can be very important. Whether you see that gray or pale blue finding associated with methemoglobinemia or the frequently described and less frequently seen cherry red skin of carbon monoxide poisoning. Do the patient have track marks? Do they have dry skin or wet skin? This is the classic description of the toxicologist handshake under the arm, where you see under the axilla if they have perspiration and they're wet, that can be sympathomimetic toxicity. If they have a dry axilla and dry mucous membranes, that can suggest anticholinergic exposure. And this can be thought of in terms of different kinds of phases of care, although realistically, we often do all of these in parallel. As we've discussed, establishing scene safety to make sure that you're safe where you're at, whether you have to move. Emergency stabilization before you start diving into fancy antidotes, considering whether the person needs fluids, whether they need dysrhythmics, whether they need an airway, assessing the patient, putting together all of the things that you're finding, your history and your physical, to try and figure out what you're seeing, considering decontamination, which we talked about doing general decontamination by removing clothing, but sometimes we also talk about GI decontamination and enhanced elimination. A lot of this will happen in other sites of care, but it's important to discuss. And throughout this, you're going to assess and reassess. Very often, recognizing that the blood pressure is dropping or recognizing that the heart rate is changing is far more important than having a detailed memory of esoteric poisonings. In terms of lab studies, I know very often this will depend on the site of care, but certainly a blood glucose in any altered patient or patient with abnormal vital signs can give you insight. If it's hypoglycemic, they might need glucose. If they're hyperglycemic and bradycardic, that can suggest calcium channel blocker poisoning. Certainly a rhythm strip or even an EKG or a rhythm strip can be helpful in identifying fatal arrhythmias, but also in identifying specific tox exposures. A chemistry or a blood gas can be helpful in identifying acidosis. A pregnancy test can tell you how many patients you're treating. And then on the other side of includes some more advanced testing that often happens in emergency departments or other sites of care. Certainly an ethanol level can be helpful. A patient that you think has alcohol intoxication, but a negative ethanol level can be important to find out. I think the UTOX is something that everyone likes to talk about and likes to lean on, the urine drug screen, but it's important to interpret it within its limitations. It has false positives and false negatives. And certainly a patient who has a UTOX positive for cocaine, but is decreased mental status and relatively lower vital signs, is not suffering from acute cocaine intoxication, possibly washout, but would be incorrect to rely too much on the UTOX in that situation. A lot of these patients will have acetaminophen and salicylates checked in the emergency department and other sites of care. And certainly, if you're worried about a toxic alcohol exposure, serum osms are frequently checked. Just to dive into this a little bit, we can talk about acidoses. I think there's often a false misperception that most toxicology occurs with an advanced full panel of testing that tells you exactly what levels of every possible substance the person was exposed to has in their body. But the vast majority of poison patients are managed without such testing. Often such testing is delayed, doesn't come in time to help the patient, and doesn't provide clinically relevant information. But what can be clinically relevant is something like an acidosis. So if a patient is found to be acidotic on their gas or acidotic on their chemistry, we often dive through the anion-gap acidosis or non-gap acidosis. If they seem to have similar levels of sodium and potassium with chloride and bicarb, so a non-gap acidosis, then you often think about renal or GI losses. But from a toxicology perspective, we might think about exposure to topiramate, exposure to acetazolamide. If they're acidotic and their bicarb is low, but their chloride has an increase, then you start to get that gap acidosis, and that's where everyone dives into mud piles. This is popular on the boards, but I've definitely saved lives by recognizing this. So certainly the M for methanol, U for uremia, D for diabetic ketoacidosis or alcoholic ketoacidosis, I throw in there, propylene glycol poisoning, paraldehyde poisoning, iron, isoniazid, especially isoniazid for that patient who's been treated for tuberculosis who won't stop seizing, inborn errors of metabolism, lactic acidosis, which we see in lots of our patients, ethylene glycol poisoning, and salicylates. I've definitely recognized a gap acidosis, checked a salicylate level, and saved a life in the past. And talking about EKGs, be it rhythm strips or 12 leads, it's important to talk about what you're looking at when you see a tox patient. Very often when we're getting rhythm strips or EKGs, we're thinking about ischemia in that patient with chest pain, but the patient who's exposed to a toxic agent has a different thought process and a different approach. So you're going to look at the rate. You want to know, are they bradycardic or are they tachycardic? You're going to look at the rhythm. Certainly if they have VTAC, if they have VFib, follow ACLS, respond appropriately. Many tox exposed patients, if they die, will die from a cardiac arrhythmia. But then you're really wanting to look at the QRS and the RNAVR. These are important findings that will change management in tox exposed patient. Classically, that wide QRS, be it 180 or 200, although for most poison centers, a QRS wider than 100 is considered concerning, and that RNAVR. That's that terminal part of AVR where you'll see a large R wave that can be greater than 3 boxes tall or wide. And both of those things, the widened QRS and the RNAVR, can suggest sodium channel blockade, and that should be treated with sodium bicarb. Failure to recognize that and failure to appropriately treat that patient can result in them having fatal arrhythmias, seizures, and ultimately dying. So in every tox exposed patient that I get a rhythm strip or a 12 lead, I always look for a widened QRS greater than 100 and an RNAVR. And I have QT on here, but please know that I have it last. I think we frequently jump to the QT in tox exposed patients, and certainly a prolonged QT can result in an increased risk of torsades, and that can be important to treat with magnesium and other agents. But from a tox exposed patient, the things that will kill them far faster are a fatal rhythm or sodium channel blockade that precedes a fatal rhythm. After knowing the patient with that history and that physical, looking at those basic labs, know the drug. This is important to apply your knowledge of toxidromes. If you want to get some help, important to reach out to poison control. I've got the 1-800 number up there. Consider a toxicology consult or medical control if you have them available, and medical references. I don't put a specific reference here because I think many of you have pocket references or protocols that you can follow that can be handy on scene. In terms of toxidromes, I find that many people have treated tox exposed patients without asking themselves, what toxidrome am I seeing? And that's a lost opportunity for improvement. I personally found that these toxidromes were hard to remember. They often felt like magic eye photos where I was staring at them and I just couldn't see it. But if you ask yourself with every tox exposed patient which toxidrome they have, you'll get far better at this. Starting with opioids, these are often the patients that we've seen that have apnea or decreased respiratory rate. Very often they'll have relatively decreased other vital signs. Now, they won't necessarily get severely bradycardic or severely hypotensive, but they can get relatively bradycardic and their blood pressure can drop relatively. Those pinpoint constricted pupils and depressed mental status. Sedative hypnotic toxidrome, I often think of as opioid light. These are the patients that get naloxone but don't respond. And a big finding in these patients is that they often don't have such decreased respiratory rates. They can have normal to relatively decreased respiratory rates and decreased mental status. Cholinergic poisoning, this can often be thought of as organophosphate or pesticide exposure. Luckily, in the United States, we see far less of this than globally, but globally it can be a major issue, certainly in an agricultural setting. So that overload of acetylcholine at the muscarinic and nicotinic receptors is going to result in bradycardia. So you often see that decreased heart rate. We often describe the killer bees of bradycardia, bronchuria, and bronchoconstriction. So important to recognize that. Small pupils often eventually occur. Diaphoresis, because acetylcholine is an important neurotransmitter for making you sweat. And very often these patients can have confusion or seizures and depressed mental status. Important to recognize the cholinergic toxidrome so you can give atropine antidotal therapy. Anticholinergic toxidrome is very often the opposite of this, and we see this far more commonly with antihistamine exposures and with other drug exposures. These patients are often tachycardic. That's the big finding that you see. A patient who does not have tachycardia and doesn't have some other rate controlling agent on board often does not have an anticholinergic toxidrome. They can be relatively hyperthermic, relatively hypertensive, but they don't have to be. And these patients, because acetylcholine is blocked, are going to be dry under the axilla, dry mucous membranes. They can often be confused or mumbling. They could be hallucinating. They can have seizures. And because of the importance of acetylcholine in the CNS, they can often have decreased mental status. Sympathomimetic, classically cocaine or other stimulants, they often have increased vital signs. These are the tachycardic, hypertensive, sweaty patients. They're agitated, they can have seizures. It's important to recognize that. And finally, hallucinogenic, which, especially with the increased advent of magic mushrooms, ketamine, and other agents, it's important to consider. And these are often more notable for the mental status change, the confusion, and the hallucinations, often disproportionate to the vital signs. How do you manage these patients? Well, number one, you want to decrease exposure with decontamination and enhanced elimination. You want to limit the damage, sometimes through administration of antidotes and often supportive care, and then watching and waiting. So decontamination, we've already talked about removing the clothing, flushing the agent. And very often with ingestions, this is where we start to talk about charcoal. So charcoal is great because it has lots of nooks and crannies, kind of like English muffins. And so if it's administered within an hour of a potentially dangerous ingestion, it can help decrease some of the drug that's absorbed systemically. I say within an hour because if it's several hours later, it rarely has a huge effect. And in many cases, it's hard to identify that charcoal has saved a life, but it can be considered. The caveat is it's really important to not administer charcoal in patients with depressed mental status. The worst thing you can have is a patient who aspirates that charcoal and ends up with charcoal pneumonitis, which can be very dangerous. So consider charcoal in potentially dangerous ingestions within an hour of exposure. Gastric lavage is something that's talked about and it sounds very interesting and it used to be a routine standard of care 40 years ago, but it's really not anymore. It's placement of a large 36 to 40 French tube. This is not an NG tube placed down into the stomach. There's lavaging with multiple exposures of often warm saline. There's concern that this can increase risk of esophageal perforation and aspiration, and really should only be used in dangerous exposures without antidotal or alternative therapies when there's evidence of pills in the stomach. An NG tube does not suck out pills, and so it's important to really take a step back and talk to your toxicologist or medical control or poison control before considering lavage. And whole bowel irrigation, honestly, especially in a patient who might have remote access to care or might have prolonged transport, is something to consider. Whole bowel irrigation is the administration of Go Lightly, often through an NG tube, to administer the 1 to 2 liters per hour in order to flush out the GI system. That's going to help flush out, especially extended release medications, decrease the total amount that's absorbed. And typically that is done until the rectal effluent is clear. So just giving someone a cup of Go Lightly is not whole bowel irrigation, but that can be a way of decontaminating and decrease exposure. Enhanced elimination is something that's often done on seen at hospitals and more advanced care settings, but something to consider, especially if you have prolonged transport time in a patient. Saline diuresis, administering 150% or 200% of maintenance normal saline or LR can help maintain GFR and might help in someone who has a lithium toxicity or another renally excreted poison. Certainly avoiding dehydration and avoiding decreased GFR can be important. So saline diuresis to maintain GFR for renally excreted poisons can be important. Sometimes we consider alkalinizing the urine. That's especially important with something like salicylate, where you administer sodium bicarb drip intravenously that gets spilled into the urine, and that alkalonic urine can help trap some of the salicylates. Certainly at hospital settings, dialysis and chelation are also considered. And very often we'll consider the administration of antidotes. This is fun and it's interesting. It's not as useful in the vast majority of cases as we think, but something to consider: administering N-acetylcysteine for acetaminophen poisoning, physostigmine to reverse anticholinergic poisoning, certainly glucagon and insulin for beta blocker exposure, oxygen for carbon monoxide. Important, many of you will have access to hydroxycobalamin for cyanide exposure if you have a house fire and someone ends up going down or becoming hypotensive, and B6 or pyridoxine for that INH exposed patient who won't stop seizing. Many of us have given naloxone to an opioid intoxicated patient, and was already discussed sodium bicarb for a patient who has tricyclic antidepressant overdose, that sign of sodium channel blockade. And ultimately, don't overcomplicate. If the person's not breathing, supportive care with an endotracheal tube is important. For hemodynamics, give them pressors, give them fluids. A direct acting pressor is going to be best. Something like norepinephrine or epinephrine is often far better than dopamine. Give an antidysrhythmic, follow your ACLS protocol if someone's developing VTAC or VFib. If they're seizing, give them benzodiazepines, and consider treating their anxiety and their nausea. So jumping back to that theater standoff, the EMS personnel that recognized that these patients had small pupils, decreased mental status, decreased respiratory rate, and didn't have the bronchuria or the sweatiness of someone with a nerve agent exposure gave naloxone, and honestly probably saved multiple lives. Even the patients that didn't get naloxone but did get airway support probably did better. So in summary, know how to evaluate the tox patient, recognize the types of exposures you're going to see, and understand what comes next. I want to give you some references. Certainly, Approach to the Poison Patient by Ken and Hurd is available on YouTube, which is an excellent resource. Your Pocket EMS reference, I'm not going to tell you which one, but any Pocket EMS reference is going to have some helpful guides with this. This is a URL that can be helpful for paramedics, the Quick and Dirty Guide to Poisonings. And some of the tables and information I used today is from the Occupational and Environmental Medicine textbook. I want to thank the Regional Disaster Health Response System for inviting me to give this talk today. If you have any questions or feedback, feel free to reach out to me at my email right there, matthew.zuckerman@cuanschutz.edu. Thanks again.